Hi, I'm Kwa, a final year Master of Pharmacy student, and today I'm going to present about pancreatitis with a focus on acute pancreatitis. So, what is it? What is pancreatitis? Quite simple. By the term, pancreatitis is inflammation of the pancreas. There are two types. Acute one comes with sudden onset and lasts for very short term from days to weeks, while chronic pancreatitis results from multiple episodes of acute one and usually lasts from months to years. We'll go through each of them in prevalence, risk factor, pathophysiology, signs and symptoms, while the treatment plan will be focusing on acute pancreatitis only. Acute pancreatitis caused 275,000 hospitalizations in the US in 2009, with an annual incidence of 20 to 40 per 100,000 persons per year. The prevalence of chronic pancreatitis is lower with 4 to 9 per 100,000 persons per year only, but does have a significant impact on patients' quality of life. Prevalence between different countries can be different due to different diagnostic criteria and local risk factors. For example, alcohol consumption used to be very common in Japan and Western countries due to their drinking culture, but then alcohol consumption has been increasing in developing countries such as China and India due to rapid urbanization. Therefore, it should be expected to increase the burden of alcohol-related pancreatitis in these countries. From gender perspective, prevalence between male and female patients with acute pancreatitis is similar, but that for chronic pancreatitis is different and often more common in male than female. Regarding age, although pancreatitis is uncommon within people less than 20 years old, it is increasingly recognized in pediatric population. And why is that? I will explain later. From race perspective, the risk of pancreatitis is 2 to 3 times higher among blacks than whites. Alcohol was shown to increase the risk of pancreatitis in a dose-dependent manner. The risk for chronic pancreatitis increases at threshold of approximately 4 to 5 drinks a day with strong evidence from meta-analysis. It is confirmed as the single most common cause of chronic pancreatitis and the second most common cause in acute pancreatitis. These data indicate a clear increase in risk among heavy drinkers, though lower levels of alcohol consumption might not be completely safe. Since 1982, when smoking was initially reported as a risk factor for chronic pancreatitis, numerous studies have confirmed this association. Smoking and alcohol are cofactors that increase the risk of pancreatitis. A Swedish study found that smoking doubled the risk for non-gallstone-induced pancreatitis. Doctors often focus on counseling patients with chronic pancreatitis against alcohol consumption and underestimate the role of smoking, therefore missing the opportunities to counsel patients on smoking cessation or to refer them to behavior modification program. There are a number of other risk factors, including diet, obesity and diabetes, gallstones, medications such as sulfa drugs, anti-HIV drugs, protease inhibitors, some medical conditions, and of course, family history. Alright, before looking into the pathophysiology of pancreatitis, we're gonna resume a little bit about pancreas. So pancreas is as long as the length of a dollar note and stays in the epigastric region of the abdomen, behind the stomach. It has endocrine function, in which alpha and beta cells secrete hormones into the bloodstream. Also, it has exocrine role, in which acinar cells secrete digestive enzymes into the duodenum and digest food. In specific, these enzymes break down macromolecules in food, such as carbohydrates, lipids, and proteins. But also these macromolecules are also found in the cells of the pancreas. To protect the pancreas, the acinar cells produce inactive forms of the enzymes, known as proenzymes or zymogens. The zymogens are activated by protease. For additional security, zymogens are kept away from the sensitive tissues and stored in the vesicles called zymogen granules. They are also packed with protease inhibitors and prevent premature activation of the zymogens, and of course prevents further cellular damage to the pancreas. To digest the meal, these zymogens are released into the pancreatic duct and delivered to the small intestine, then activated. They are called trypsin. Now trypsin are the active enzyme of pancreatic zymogen, called trypsinogen, formed by enteropeptidase, a protease found in the duodenum. If trypsinogen is activated too early, it can cause acute pancreatitis. This might happen as a result of any injury to the acinar cells, or anything that prevents the normal secretion of proenzyme into the duodenum. The two leading causes of acute pancreatitis are alcohol abuse and gallstone. Now, have a look at acute pancreatitis first. In acute pancreatitis, pancreatic tissues are destroyed as a result of protease and inflammatory response of the body. This can cause tiny blood vessels become leaky and sometimes rupture. Ultimately, all of the extra fluid or edema cause capsules of the pancreas to swell, and unfortunately, there could be some activation of lipase, which destroy the fat around the pancreas, or peripancreatic fat. All of this digestion and bleeding can liquefy the pancreatic tissue, called liquefactive hemorrhagic necrosis. In specific to alcohol-induced acute pancreatitis, alcohol increases the secretion of zymogens from acinar cells, while it decreases fluid and bicarbonate production from the ductal epithelial cells. As a result, the pancreatic juices become very thick and potentially form a plug and block the duct. A blocked duct is bad news because pancreatic juices start backing up, increasing pressure and distend the duct itself. This causes membrane trafficking, and zymogen granules may fuse with lysozymes, which convert trypsinogen and trypsin, causing cascade of digestive enzyme activation and autodigestion of the pancreas. Alcohol can also cause acute pancreatitis in another way, for example, stimulating acinar cells to release cytokines, triggering immune responses. Neutrophils are quickly attracted to the site and release superoxide and proteases, which contribute to the problem. Finally, in high consumption of alcohol, subsequent oxidative metabolism of alcohol might produce enough reactive oxygen species that overwhelm cellular defenses mechanism and damage themselves. With gallstones, sometimes they can get locked in the sphincter of Oddi, which block the release of pancreatic juice, which is pretty similar to the results of alcoholic acute pancreatitis. Other causes of acute pancreatitis that often lead to chronic pancreatitis include trauma to the pancreas, tumors, and cystic fibrosis. Just a slight cut, in cystic fibrosis, there is a mutation in the CFTR gene. This gene encodes iron transport, and such mutation makes pancreatic secretions become thick and sticky, which lead to blockage of the duct. I mention that because cystic fibrosis is the main cause of chronic pancreatitis in children. So, what about chronic pancreatitis? Repeated episodes of acute pancreatitis can progress to chronic pancreatitis, with each episode has the potential for ductal dilatation and damage to the pancreas tissues. As far as the subsequent healing process, pancreatitis stellate cells laid out fibrotic tissues which cause narrowing or stenosis of the duct, as well as acinar atrophy. In addition, in certain conditions like alcoholic acute pancreatitis, calcium can deposit on plaques formed in the pancreatic duct. This gradual process of healthy pancreatic tissues getting replaced by misshapen ducts, fibrosis, and calcium deposits is chronic pancreatitis. So, what is the clinical presentation of pancreatitis? In acute pancreatitis, general symptoms include pain, nausea, and vomiting. There are distinctive signs, which include hypocalcemia caused by calcification around the fat necrosis. There's also Cullen signs, which is bruising around the belly button, or Creighton sign, which is bruising along the flank between the hip bone and the ribs. This results from hemorrhage, which will be explained later in the complications section. In chronic pancreatitis, epigastric pain that radiates to the back is more typical and may or may not link to meals and often last for hours. Without digestive enzymes, fat may pass through the intestine undigested, leading to greasy and smelly stool called steatorrhea or fatty stool. Another symptom is creatoria, which is muscle in stool. So, how are we going to diagnose pancreatitis? First of all, there will be pain in epigastric region, which radiates to the back. Elevated lipase and amylase more common and specific in acute pancreatitis, while in chronic pancreatitis, there may not be enough healthy tissue to produce the enzymes anymore, so the serum level can be normal. Often diagnosis relies on imaging studies that can identify the structural changes in the pancreas. For example, abdominal X-rays or CT scans may show inflammation, necrosis, and pseudocyst, as well as calcification in the pancreas. Ultrasound may show gallstone as well, if expected. The pancreatic ducts themselves can be visualized with endoscopic retrograde cholangiopancreatography, or ERCP. An endoscope is passed down through the mouth to the duodenum, deliver contrast medium to the pancreatic ducts. Results can be shown with structural changes in the pancreatic ductal system, like anastenosis, dilation, etc. An alternative imaging method can be used is magnetic resonance cholangiopancreatography, or MRCP. Now, after making a diagnosis, doctor also use some criteria to determine the severity of the condition. In this slide is an example of Atlanta criteria system for mild, moderate to severe acute pancreatitis based on determination of organ failure. Now let's talk about some complications. There are local complications including ascites and fluid collection. Some people develop pancreatic pseudocyst, as in the photo. Ductal obstruction increases pressure and leakage, leading to accumulation of peripancreatic fluid in fibrogranulation tissues, either within or just outside the pancreas. Pancreatic pseudocyst has the potential to rupture, causing hemorrhage and the releasing of pancreatic enzymes into abdominal cavity, which will lead to massive inflammatory reaction. Hemorrhage from damaged blood vessels can quickly develop into hypovolemic shock. That pseudocyst can also be infected, usually by E. coli, and turn into dangerous pancreatic abscess. Sometimes it can develop to necrosis, which is a life-threatening issue, which can lead to death. Another dangerous complication is systemic activation of coagulation factors, or disseminated intravascular coagulation, or DIC. In this scenario, tiny blood clots are formed throughout the body, using up all clotting factors, leading to paradoxical effect of bleeding, which will damage a lot of organs. Finally, acute pancreatitis can cause acute respiratory distress syndrome, or ARDS, also a result of leaky blood vessels in the lungs causing breathing difficulty. ARDS is among the leading cause of death in people with acute pancreatitis. As the acinar cells become impaired, they produce fewer digestive enzymes, result in pancreatic insufficiency. This leads to trouble absorbing food and fat, causing weight loss, deficiencies in vitamin A, D, E, K, like fat-soluble vitamins. Prognosis of acute pancreatitis is pretty bad with 15 to 40% of patients have organ failure within the first 24 to 48 hours. If not appropriately treated, 50% of them die within the first week. And if everything is all good, repeated acute pancreatitis will lead to chronic pancreatitis, and that will cause malnutrition and vitamin deficiency, which significantly affect patients' quality of life. Now, what are the treatment arms for acute pancreatitis? We will be looking at fluid and electrolyte replacement, rest the bowels if needed for the pancreas to heal, explore any potential causative factors and treat them, nutrition support, pain control, and last but not least, supportive therapy like oxygen dialysis. Now, why fluid replacement is critical in acute pancreatitis? Let's look at the flowchart in here. As we remember, initial local pancreatic inflammation triggers the release of many inflammatory mediators which lead to vasoconstriction, causing ischemia. Capillary permeability is also increased, causing leakage, intravascular fluid loss, and hypotension. This eventually can lead to shock and death. The first 5 days after the onset of acute disease are considered as the therapeutic intervention window, during which aggressive fluid resuscitation can correct the third space loss and increase tissue perfusion. In specific, aggressive hydration is recommended for all patients unless any cardiovascular or kidney diseases may contraindicate. This is defined by 250 to 500 ml per hour of isotonic crystalloid solution, such as lactate rinsure, plasma-lyte. Hydration should be implemented as soon as possible, and evidence shows strong benefit within the first 12 to 24 hours, while little benefits received thereafter. Fluid resuscitation should be reassessed every 6 hours after admission and for the next 24 to 48 hours. Target is to bring blood urea nitrogen back down to normal, with strong evidence. If cholangitis is diagnosed with acute pancreatitis, ERCP should be performed within 24 hours of admission. The goal is to remove obstructing gallstones or any obstruction and reintroduce clear pancreatic ducts. This will prevent progression of acute pancreatitis to severe states such as organ failure and necrosis. Antibiotics are not recommended as prophylaxis and only when an infection is confirmed, such as catheter-acquired infections, bacteremia, urinary tract infections, and pneumonia. Sterile necrosis does not require antibiotic. Infectious necrosis should be suspected in patients who deteriorate after 7 to 10 days of hospitalization. In case antibiotics is used, it should be used no more than 14 days from the absence of positive cultures. Regarding nutrition, oral feedings can be applied if no nausea or vomiting and abdominal pain is resolved in mild acute pancreatitis. In this case, low-fat solid diet is recommended as safe as clear liquid diet. In severe acute pancreatitis, while previous guidelines suggested new by mouth, the American Society of Gastroenterologists recommends enteral nutrition over parenteral to prevent infectious complications. In this case, nasogastric and nasojejunal delivery are equivalent. Some studies suggest the use of enzyme supplement like creon, but the evidence stays unclear. Pain management is also important, as such severe pain in acute pancreatitis is a triggering factor for further inflammatory cascade, which will worsen the condition. Patients usually describe this type of pain as excruciating pain, and therefore morphine or opioid can be indicated from low to high doses as needed. In the event of acute renal failure, Dialysis is recommended with the main purpose of balancing the fluid and some vital electrolytes like sodium, potassium. And of course, in such case of severe acute pancreatitis, patients should be closely monitored in the ICU. In necrotizing pancreatitis, biopsy should be obtained within 7 to 14 days from the onset of acute pancreatitis. Then, surgical debridement can be performed to remove as much cavities as possible that contain necrotic tissues, and of course, alongside with all other above fundamental treatments. Now, in summary, looking at the management plan, if we make the right diagnosis within the 48 hours using sign symptoms, imaging and laboratory results, as well as some criteria for classifications, and then we provide the right treatments within 24 to 48 hours, including fluid resuscitation, nutrition support, pain control, treating underlying causes, and supportive care, we can significantly reduce mortality rate down to less than 10% instead of 30%. To make it easier for you to understand, let's watch this video about a doctor who went through acute pancreatitis and share his stories with us.
We've always known each other. We went through nursery school, kindergarten. We have so much common history between the two of us. My best friend.
I married my childhood sweetheart. We've been together 50 years, married 25. All I ever wanted to be my whole life was a hand surgeon. Started my career at the Cleveland Clinic in the early 90s. I actually left the clinic for a decade, and I had the opportunity to return to help advance the creative thought that is coming from Cleveland Clinic Innovations. You're told the first day of medical school, you eat when you can, you sleep when you can, and you don't ever mess around with a pancreas.
It was around 6 o'clock, and he was lying in his recliner in his office, and I said, "Are you okay?" And he says, "Yeah, my stomach hurts a little bit. I feel like I have a gas bubble." He said, I'll be fine, I'll be fine." Well, within 20 minutes, he was on the floor and really couldn't get up.
Felt like somebody cut me wide open and put a red-hot frying pan in my abdomen. And that happened over minutes.
They took him to Hillcrest, and we didn't know at the time what was wrong. And then they said it was pancreatitis.
The gallstone, of which I was unaware, lodged in the pancreas. Well, the pancreas essentially is filled with battery acid, helps you digest your food. So when your pancreas explodes, as mine did, it's essentially like getting a third-degree burn of all your abdominal contents.
He had what we call severe necrotizing pancreatitis. The pancreas literally digested his organ and everything back there. So it's like a little nuclear bomb going off in the back of your abdomen.
As time went on, more and more of my organ system started to fail.
He was really going downhill. And then they intubated him and decided to send him down to main campus.
I was being loaded on the helicopter. I'm intubated, on dialysis, with a cardiac arrhythmia. I realized that this may not end up with a favorable outcome.
They brought him right in to the ICU, and he had wonderful doctors, wonderful nurses taking care of him up there.
The tendency with pancreatitis, because the patients are so sick, is to, quote, do something. But really it's that first 7 to 10 days where it's just all supportive care, which is the major hurdle.
If you don't treat the initial part right, people go into shock like they were in a battlefield. They just go into shock and they die from shock. So we're trying to prevent that.
And then ultimately, we were able to go in about a month later and drain and debride the pancreas that had died.
I had 20 operations or major procedures. I had drains in, essentially kind of garden hose sized tubes, 4 of them for most of a couple months. I was being sustained only by tube feeds. I lost 50, 60 pounds, lost so much muscle mass that it was very difficult to do almost anything. So over the 4 months of hospitalization, we really were touched by almost every one of our institutes in one way or another. And what resulted, again, was almost this symphony of people working around me and on me to try to pull me through.
Matt Walsh would say, you're going to go along and everything's going to be just the same, and then one day you're going to feel better and you're just going to skyrocket. And that's exactly what happened.
Every time I say, geez, you guys saved my life, they always say it was a huge team, which I think is indicative of the way we do things here at the Cleveland Clinic. I'd never lived on the other side of the bed rail, but now having done so for 6 months, what I saw and found and thought about while I was counting ceiling tiles for months at a time. There's no greater calling than to assist your fellow man, especially in their most difficult of times. The true patient experience is unparalleled, and it pervades everybody you touch at our organization. Everybody feels that they are part of the patient's journey and are just as integral as the surgeon operating on you to your recovery.
Tom is so honored to be part of the clinic, and we came back almost 4 years ago, and there were a lot of reasons why we came back, but this was the real reason. And I know I wouldn't have him. He wouldn't be here if we weren't here. So it's a gratitude that you can never repay.
I've been given a new lease on life, a mulligan, if you will. So my charge is to make sure I live up to deserving it, and I thank the Cleveland Clinic every day for it.
So what are the takeaway messages from the case? First of all, necrotizing pancreatitis is a critical condition that requires immediate medical attention. Time really matters. As you can see, you have to make the right diagnosis and provide the right appropriate treatment within 24 to 48 hours. Fluid replacement and nutrition support are key. We also need to treat the causes, which is gallstone in these patients. We also need to treat complications from the pancreatitis by dialysis, ICU care. As you can see in the video, the patient has renal failure. And of course, the recovery journey does require support from family and friends as well. Now, last but not least, I'm going to talk about some limitations and future developments in acute pancreatitis. For some limitations, at this stage, there are only general treatment on complications and causes, like we treat the shock, we treat renal failure, we treat gallstones. There has been no specific treatment for acute pancreatitis so far. ERCP is a useful diagnostic tool and treatment tool, but can cause pancreatitis itself. Now, for current and future developments, we do have infliximab, which is a monoclonal antibodies that has been proven in some rat studies that can reduce amylase activity and reduce parenchymal and fatty tissue necrosis, as well as reducing ARDS and pulmonary complications and systemic complications of acute pancreatitis. Probiotics prophylaxis has been proven to have promising outcome in preventing septic complications, especially in severe acute pancreatitis. This result is from a double-blind placebo-controlled and randomized multicenter trial, so quite promising in the future. And those are some resources for your further reference. And that's at the end of my presentation. Thank you for your attention.